Jim, this is probably one of my most favorite cases. This is a 30-ish-year-old woman who came to see me. She had a breast augmentation done, and she had 3 complaints. One was that her breasts were too big. Another was that her nipples were pointing kind of inward. But the thing that really bothered her is she had Symmastia. She had a unibreast. The skin was actually lifted off her breastbone, and she wanted to know how I could help her.
Well, Mark, you know, this is a very challenging case. I mean, I think you really nailed it. I mean, what do patients want? They don't want one breast. They want 2 breasts. They might want a fuller breast, a bigger breast, a more attractive breast. They certainly don't want one breast in the middle of their chest like a cyclops. So tell me what your thinking was and how you went about correcting this problem for her.
Well, this is not the kind of case you can look at in 30 seconds and say, oh, okay, here's what I need to do, X, Y, and Z. At least that's not for me. So I gave this a lot of thought. There are a few problems here. One, her implants are too big, and it's too tight for the envelope, and that forced the crease down, and that needs to be corrected. Putting in a smaller implant certainly will help with that. But the unibreast, the Symmastia, that was the real key thing. Now, fortunately for me, the pocket the original surgeon used was above the muscle. So now I had the luxury of making a pocket under the muscle, which is my preferred approach for a primary for first-time augmentation anyway. And I was able to use some of the capsule that had formed to act as an extension of the muscle to help secure a smaller implant in the proper location and help bolster the repair of the crease at the same time. And then that naturally took care of the unibreast, because the muscle now acts as the baffle to hold the implants apart, and the smaller implant satisfied that for her. And now that the Symmastia was taken care of, the nipples are no longer pointing inward, and the crease has been raised with sutures and secured with that capsule. So that took care of all the problems at the same time.
Well, Mark, I have to compliment you. It's a spectacular result, and only a surgeon can really appreciate what you did to get to this endpoint. It's outstanding. And what this shows is that a wise surgeon who executes excellent judgment in the selection of devices, the decision about which pocket to use, and then executes the operation properly can get this kind of outstanding result. One last question for you. Mark, if I was that patient and I came into you and I said, you know, Dr. Epstein, I love what you've done, but I wish I had a little bit more stuff at the top, right in here in what's called the social area of the breast. I don't want them together, but I want more softness. Talk to me about what you might have suggested to her about how she could accomplish that goal without using a bigger implant.
One of the great options that we have now, and it's very popular, is fat transfer. It's been perfected. There is wonderful instrumentation to it. We can do it with negligible complication rates. It doesn't take long. It's not a lot of downtime. Take some fat from the abdomen or the flanks or the hips. You don't need a lot, and you can put some of it into the top of the breast. And should you need to do a little touch-up later, it's an easy matter to take. You can do it under local anesthesia. Take a little bit more fat and do a little touch-up if you need to. And that can make the difference between a 95 and a 99 result.
Yeah, and I'd say that if I was a patient looking at this, I'd say, this man's a pro, and that's who I'm going to.
You are too kind.